off, please. Thank you. And we're also recording the meeting, so by remaining in it, you're consenting to being recorded, and the recording will be put on our website.
Okay, thank you very much, Sarah. So let's get going. Can I give a warm welcome to everybody, including the public and the media who are here. We're also going to have Alison Everson, who is observing today. So that's prior to starting as the board chair on Monday, the 10th of October. So welcome to all of you. If we can go to the apologies, please, Sarah.
Yes, we've got apologies this morning from Amy Anderson, Rona Atkinson, Batty, Caroline Hiscox, and Pam Milliken and Simon Boker-Ingram. Okay.
Okay, thank you very much, Sarah. But as you say, we're quorate for the meeting. The declarations of interest, can I ask, are there any for the agenda that we've got today? Okay, I'm not seeing anybody signalling, so we'll record none for today. That's fine. So that takes us to item 3, which is the introductory remarks. So I'll go first and then hand over to Adam. I've got a few things I'd like to go through. First of all, since this is the first board meeting since the passing of Her Majesty the Queen, on behalf of the board, I would like to formally extend our condolences to King Charles and indeed all of the royal family. We were honoured to welcome the Queen to our facilities on several occasions and feel privileged to have received her supportive presence in Grampian over the years. I'm pleased to be able to highlight that we have reached a significant milestone in the construction of NHS Grampian's Anchor Centre. It'll open its doors in a year's time. This facility will welcome some 65,000 patients through its doors every 12 months, as well as providing a much improved environment for our colleagues and who are working with these patients. We can now see the finished building, what it will look like since the external render has been applied, and a good amount of glazing has now been installed, which will maximise the natural light within the building. This is one of our exciting projects, and it will transform facilities for both colleagues and patients. I'd also like to draw the board's attention to NHS Grampian's support for the inaugural Speak Up Week. This is taking place this current week. It's a new initiative launched by the Independent National Whistleblowing Officer, which will create opportunities to engage staff about the benefits of speaking up and the difference it can make within the NHS in Scotland, clearly for our colleagues and for our patients and for the public. NHS Grampian has a clear ambition to create a positive culture that welcomes whistleblowing concerns, handles them openly and transparently, and has a focus on system-wide learning and improving. As board members, we have a critical role in setting the tone and creating a culture that values the contribution of all staff, including those who identify the need for changes through speaking up. Turning now to the business on our agenda today, let me signpost to 4 of the reports. The performance report. This gives us an opportunity to discuss the recent system pressures which have prompted the media statements about using the emergency department for life-threatening conditions only to alleviate that pressure. Adam will say a bit more about this in a moment, but I wanted to, on behalf of the board, acknowledge the magnificent efforts of colleagues working across the system, colleagues working in unscheduled care and planned care across our various sites, partners in the Scottish Ambulance Service, and all those in social care, who are all caring for an increasing number of frail and very unwell people. When we get to that item, there'll be quite a few inputs, so I'd ask board members to accept that our questions will come at the end of that. It's a fast-moving situation. It's important that we get the context and then do our scrutiny on the basis of that. Next, just a moment on the delivery plan to March 2023, which has been created to specifically address these challenges that we face. The Scottish Government has now approved it, and so it's here for our endorsement. and there'll be a summary version for our colleagues and for citizens to support the communication of our key priorities. We're also provided on the agenda today with an update on the strategic review of Dr. Gray's Hospital, a critical part of our network, and we have a paper asking for approval of the preferred site for the National Treatment Centre, another exciting capital project that will help transform the care and how it's provided. I'd now like to formally welcome two new members to our board meeting today. Stephen Lindsay, who officially took up the employee director role on the 1st of September and is now a non-executive board member. Stephen has worked for the NHS since 1997 and most recently is a member of the Scottish Workforce and Staff Governance Committee. Alex Stephen, also, he's our new Director of Finance, joining us from Aberdeen City IJB and Aberdeen City Health and Social Care Partnership, where he was Chief Finance Officer and Deputy Chief Officer. So welcome to you both. We very much look forward to working with you. Finally, a personal word from me. Alison, as I mentioned earlier, has now been appointed as our new chair and starts post on Monday. As I mentioned earlier, she's an observer today, but we'll all have the opportunity to meet her and welcome her very soon. For myself, I've been very pleased to make a contribution while serving as interim chair of the board for the last 16 months. And I'd like to thank Luan Grujon, who has served as interim vice chair so effectively also through that period. It's been a most challenging time for the NHS, and so I'd like to put on record a thanks to Caroline, to Adam, to Sarah, and all the chief executive team for their support to us in our roles, and to thank all the board members, all of you also, for your support. We're an ambitious, cohesive board, and I know that Alison will find the role rewarding and will receive the support she needs from you all. I'd now like to hand over to Adam for some opening remarks of his. Thank you.
Thank you very much, John. John, I know that I speak on behalf of all of my colleagues when I say it's been an absolute pleasure working with you as the interim chair. You've been incredibly supportive of us all during such a challenging period, while still ensuring that both you and the board has provided constructive challenge and fulfilled its role in governance terms. I know and have experienced firsthand what an effective advocate for NHS Grampian and our progressive way of working you have been in national forums. And this has undoubtedly helped to promote this model and the very significant interest that is shown from many in government about what we're trying to do through the plan for the future. I'm really pleased that we will all, and me especially around the visioning and the planning work, but that we'll all still be able to draw on your experience, your very wise counsel as you continue to serve on the board. My thanks to you, John. We're all looking forward to working with our new chair, Alison Everson, and helping her understand and navigate the complex health and care system and the many challenges that we face over the coming period of time. And through that, ensuring that Alison, in her role as chair, can successfully lead the board in its next chapter. So welcome, Alison. John referred to the extreme pressure that we're experiencing in unscheduled care at the moment. And I'm not going to say actually anything in detail now, as I think it will fit extremely well into the performance agenda item that follows shortly. And I think Professor June Brown will lead on this update. However, I think it would be very appropriate for me to reinforce some of our key messaging at these times of great service pressure. I don't for 1 second underestimate the anxiety that this causes for people in Grampian, those who are unwell and need to access care. I'd like to remind everyone that in many cases where someone's not seriously ill, the emergency department is simply not the best or appropriate place to get care. And I would again urge everyone to consult the Know Who to Turn To information on our web pages, which sets out very clearly the pathways of care which are available to everyone. Whilst mentioning this delivery pressure, I would also like to extend my thanks to all of our colleagues in every role, all roles which contribute to our system. This is for their commitment, their dedication to providing the best possible care for everyone. And this is while, of course, across the whole system, we're experiencing such very challenging circumstances. The only other issue I'd like to flag just now is the significant challenge that lies ahead of us this winter. The potential impacts upon the delivery plan, which we're going to consider later on in the agenda. So to mention just some of the risks, I'd highlight the potential for further surges of COVID and the incredible unpredictability of this, the potential for the normal respiratory or flu-like disease associated with winter, through to the ongoing and enduring pressure which the system is currently facing. These, of course, will create challenges for both our staff and our staff's well-being, whilst also threatening the model of delivery that we deliver and is used by all of our patients and the population. So our aim during this winter is to manage the unscheduled care really, really well, whilst protecting the delivery of planned care. We've got good and robust plans in place, which we'll formally share with the board at the December meeting. And I think Nick Fluck, Sandra McLeod and Paul Baku will all say something further about these issues later in the meeting. And of course, one further challenge, which I must mention, and again, we'll explore in much greater detail later in the meeting, is the financial challenge. We're all facing that. We're all very aware of the inflation, the energy costs, the pay awards, positive investment to achieve net zero carbon, and the ongoing financial burden that's associated with COVID. So again, we'll pick these things up later in the meeting. Our ongoing conversation with both colleagues and citizens of Grampian will be necessarily frank and honest over the months ahead, as we seek to navigate these challenges whilst continuing to deliver safe, high quality and sustainable care. Thanks, John, and back to you.
Many thanks, Adam, for that perspective. So can we move to the next item, which is the minute? So we've got the minute of the 4th of August on page 3 of our pack of papers. Can I first of all take that for any points of accuracy? If anybody can signal for that. I'm not seeing any hands up, so we'll take that as an accurate record. Thank you very much. Next, can we take it for any matters arising? I have one, but I'll wait until others have come in on this. Again, if you can signal if there is anything. Okay, I'm not seeing anybody signaling. So the one I would like to highlight is just for clarification at item 9, bottom of page 9 on the pack. Sarah, can I just ask you to clarify what we have there about the risk appetite statement and a follow-up for the board?
Yes, we're still looking for a date, unfortunately, for a workshop for you all to discuss a risk appetite statement. So we'll endeavour to get that in the diaries as soon as reasonably possible, but before the December board meeting. And I'm sorry we haven't managed to do it before today.
No, that's fine, Sarah. It's just for clarification. I think with all the pressures that there are, everybody's understanding of that. But that would be welcome if it's in place before the December board. Thank you. Okay, so that's the minute dealt with. If we can move to the next item, which is the System Pressures Performance Report, item 5, page 12 in the pack. And Kate, the Chief of Staff for the Chief Executive, you oversee this for us. Could I ask you to come in and also introduce colleagues on this?
Thank you, Chair, and good morning, everyone. As John said, you have in your packs the performance report beginning at page 12. The accompanying dataset Appendix 1 remains in the format which focuses on the system pressure data at a point in time, as we've considered at the board throughout the pandemic. As is set out in the paper and as we've previously discussed at the board, a refreshed performance assurance framework is under development for NHS Grampian, and at the same time drafts of new formats of reports to align to the framework are being developed and co-created. The first draft of a new report format for the board will be shared later this afternoon with the board. Turning to the data set at Appendix 1 we are considering this morning is the position at the 14th of September. You will have seen the data shows a general increasing pressure across our system, with our system escalation system, GOPES, levels rising and ambulance wait times at our emergency departments continuing, as mentioned by John and Adam in their opening remarks. For elective care, and you will note a return to data expressed on page 25 of your packs, back to TTG, time to treat guarantee. Elective care continues also to have a very challenging position. Hospital bed occupancy across the system has been increasing and is at very high levels, with similar capacity challenges for social care and care homes across the very interlinked system. Clearly, the report sets out continuing pressure and challenge, and the work to respond across the system continues at pace. As Adam suggested in his opening remarks, I am now going to hand over to some of our executive leads for some of these key areas to give a bit more detail of the work underway. So those will be firstly June Brown, our Executive Nurse Director, to give an overview of the impact of the continuing unscheduled care pressures. Nick Fluck, our Medical Director, will share information in relation to our overall planning for winter. And Sandra MacLeod, in her role as Medicine and Unscheduled Care Portfolio Executive Lead, will share the unscheduled care improvement work that's underway. And finally, Paul Bicou, as Portfolio Executive Lead for Integrated Specialist Care, will talk to planned care and cancer position. Following that and questions from the board on those matters, we will come back to Appendix 2, the Financial Performance Summary Report. So I'll hand over to June Brown now.
Thank you, Kate, and good morning, everyone. It's really important that we acknowledge the significant and sustained pressure that we have on our system, and it's our whole system. The board were briefed on Tuesday in relation to our experiences at the weekend and the impact that's had on our unscheduled care delivery. Last weekend was particularly challenging, seeing a business continuity approach being utilised to be able to support and relieve the risk that was experienced, not only by ourselves but by our partner Scottish Ambulance. The causes of this pressure are really quite multifactorial, including in particular the acuity of our patients seeing our resus department being at its maximum capacity for the majority of the weekend. Our patients are very sick, therefore they're staying in hospital longer as well. The flow out of the hospital is another factor that contributes to this, and there's various reasons for that. That would be including some of our care home access, transfers of care, and our delayed discharges. Other challenges include our reduced staffing, not just in our hospital setting, but also our care at home facilities and services, as well as our community hospitals and care homes. I hope that sets a bit of the picture. I'll hand over to Nick.
Yeah, thanks very much, June, and thanks very much, everyone. So what I thought I'd do is just talk about a couple of the elements in terms of how we're bringing together, if you like, our tactical plan for sort of winter and the next 6 months. We've sort of taken this approach over the last few years, and firstly, what I wanted to say was a little bit about scenario planning. So as Adam picked up in his introductory remarks, there are a number of sort of considerations as we go into the winter time. We've really benefited from our academic public health colleagues and university colleagues in the last few years in really accurately looking at what do those pressures mean when we look at different scenarios. So really, just talking about those, we've got the traditional scenarios that we've used, which relate to sort of adverse winter pressures associated with weather events and those sorts of things. We've also clearly now got experience in terms of infection and a viral episodes such as COVID or flu. But on top of that, we have a sustained pressure environment, which we are starting to understand more, which is built on the post-COVID era. And in addition to that, we're aware that some of the economic pressures in society will also have a very significant impact on how people are able to utilise healthcare systems and also directly in terms of healthcare outcomes. Now, in the last couple of years, we've focused quite a lot on looking at bed demand that's associated with these scenarios. We're probably changing chat very slightly in the sense that whilst that's really important, we're also trying to understand where in our system, whether that's around disease specifics or in terms of which parts of our society are going to be most impacted based on different scenarios, because that allows us to think about how we nuance our response. So broadly, based on that type of work, we're pulling together a plan that's got three core elements. The first is really what's our business as usual approach, and we've already heard alluded to the operational pressure escalation system. That's essentially our operational business continuity system. That's in place. It's going through a period of just revision, just to make sure we've got as many of the tweaks done as possible around that going into the winter. Secondly, we've got our portfolio and system management approach, which is really, for those that don't know, during the week we bring together the entire system. So that's with our partners such as the ambulance service up to 3 times a day to bring everyone together to see how we share intelligence and how we share mutual aid and support across the whole system. So that approach is extant. On top of that, our second area is around essentially an unscheduled care improvement plan, and that's got a number of sub-elements to it. One which is around the redesign of urgent care, the second which is around the national urgent and unscheduled care collaborative, a number of national projects under that, and then thirdly around optimising patient flow. Now these, and Sandra I think will talk to a couple of the elements in terms of some of that improvement. I think what's really, really important, these first two elements, which is, if you like, our normal approach to business and our improvement plan, are spec'd out and designed that they protect the other important things around that. So that's around plan clear is protected, education, training, we've got to train the workforce for the future. So all of those things need to be protected as we deliver our regular business approach and our improvement approach. The third element, though, crosses a boundary on that, and this is what we put under our contingency arrangements. So this is what do we do when our capacity and system is exceeded in terms of what it can deliver in those areas. And that will be plans which were around capacity surge. They'll be about specific event responses. So what do we do in adverse weather, power outages, these sorts of things, right up to the point of major civil contingencies response. And so the important thing about those responses when we switch them on, they potentially do have an impact in other areas of care because we're responding to something that's unusual and unpredictable. So that's essentially what we're after, a tactical plan with 3 main core components. We're going through the drafting stage and the consultation, and we'll bring that back for the board to have a good discussion around that and to sign that off. So I think it might be helpful just to have a couple of highlights in terms of what are some of the improvement elements that we're trying to sort of deliver within that plan. I think Sandra was going to pick up on a couple of those. So thank you very much.
Thank you, Nick. Thank you, everyone. So I really just wanted to highlight, as Nick said, just a couple of key areas. So we are working with colleagues right across the system to look at ways we can work differently. I think that's really important to understand that we're working, as Nick said, with colleagues from our Scottish Ambulance Service, from our Health and Social Care Partnerships, with our third and private sector colleagues. We are focusing on 3 key areas that we've worked with the system across the past 10 weeks to really understand what we believe could make a difference in helping us move forward. So 3 key areas are going to be our focus for the next, for October, November. And we're going to look at hospital at home, so increasing our capacity across the whole system and really understanding how we can deliver that in a different way. Cardiac cath labs, which is really just about increasing our capacity. Again, that's from some chronic diseases to help that move forward. And the third area is about our triage and assessment. And that's the areas where people are coming from, right from when they first make a phone call to then being admitted into a potential an ED. So that's, if people are not going to the right places, what can often happen is, as you've seen at our front doors, is that people will then have long waits. So people who are iller are having to wait in really poor condition, in difficult situations. So one key example that we've set up a test of change this week, just really on the back of the pressures that we had at the weekend. We've accelerated one of those tests of change, and we're working alongside Scottish Ambulance Service this week. And what we've put in place just yesterday is a call before you convey, which ultimately means that if the ambulance staff have direct access to a professional line called our Flow Navigation Centre, and there they can have access to direct access to a consultant, and they can have a discussion with that consultant at the point of still being in the person's home. So yesterday, with our early start, what happened of 48 calls that came through, 25 people were redirected to alternative routes. So that meant 25 people didn't need to come into hospital. Their outcomes were far better, and that's an improvement for people's outcomes, not having to wait. So I think that's just really, again, emphasising about the right time at the right place by the right person, and hopefully we'll continue to see some improvement from there. I think, as Nick said, our focus is about, this is our business as usual, this is about our redesigning, but ultimately is about protecting our planned services so that we can then look forward to moving forward. So I'm going to pass over to Paul, who will probably pick up on some of those areas.
Thank you, Sandra, and good morning, colleagues. The area that I've got is the planned care data. The data was shared with you all, but I think it's important to start by just reminding us all that we should continue to consider the data that is only a point in time in the context of the enduring challenges that have been either exacerbated or precipitated by the previous 2 years. So that data needs to be considered very much in that context. And we continue to maintain a strong focus on people, both the citizens and the staff that provide and manage planned care. Overall, our focus has to continue to remain very much on risk, and risk in terms of clinical risk. However, we're very, very aware that that clinical risk has also got to be balanced by the priorities and targets that have been set for those who have waited far too long for planned care. Absolutely unacceptable position. However, those the capacity has to be considered, and those risks need to be judged and managed. We're doing that by looking at our internal efficiencies, our internal additionality, and opportunities both regionally and nationally. We've had to re-examine our approach to the balancing those needs in light of the national financial challenges that we have. So we're looking to the region, and as an example, we have a national treatment centre coming online later this year in Highland, and we have a proportional allocation of capacity there. We're looking nationally at the Golden Jubilee, Forth Valley, and other settings, and indeed the Centre for Sustainable Delivery and the National Elective Care Unit, NECU, helping coordinate care. Some of the things that we would traditionally have relied on, like the independent sector, to produce a surge in performance and productivity, have had to be significantly reduced because of the financial situation. Our internal processes, as we measure them, appear to be within acceptable levels, and certainly within the distribution across Scotland Further changes and improvements will be slow, but will give returns over time. Regional working is easier to say, but not so quick to deliver. But there is definitely, as shared with the Highland example, opportunities that were not present previously. The national working, not only do we have access to capacity, but there is a national focus on things like access policy. And one national access policy is the reasonable offer, and that's been implemented. Previously, it was reasonable to give any citizen within Grampian a offer of treatment within the health board. That now extends across Scotland, so it is considered reasonable to offer an individual in the city centre an opportunity for treatment at the Golden Jubilee as a routine. So there's some of the things that we're doing in planned care. Thank you.
Okay, thank you, Kate. I think that's the all of the inputs. Yeah. Okay. Thank you very much for that. I found that extremely helpful, which a highly complex and shifting position, just giving us that overview. So that's been valuable, I think, for us now to undertake the scrutiny of this. Can I just open that up for questions and comments from the board and all of those present? Thank you. Bert, would you come in, please?
Good morning, everyone, and thank you, Chair. I've got two comments and two questions, but firstly, I would just echo the comments that the Chair made earlier on regarding the acknowledgement for the efforts that staff are giving for this very, very difficult time that we are enduring and likely to endure for some time to come. My comments, firstly, I think as Paul said, when you look at the data, it is very much about point in time, and while that will fluctuate, no doubt we are going to be in that position for a little while to come. My second comment is in relation to the innovative and thoughtful ways that are being considered to try and make a difference. And I was interested in the input from Sandra about the direct contact from the ambulance people to the consultants and, the outcome that led to 25 patients being treated either in a different way or in a different place. I think that's an excellent initiative, taking account, I'm sure as it does, of the clinical risk associated with that. My two questions now, in acknowledging all of the pressures that people are under and some of the communications that we've been receiving, I noted that there were 2 or 3 days where the pressures were extremely significant, and public messaging went out, and I think we've heard about that this morning. So my question in relation to that is, bearing in mind that people who are in a difficult situation with emergency considerations as members of the public, what messaging was actually used to reach the members of the public? And do we know how effective that was? Do we know what difference that actually made? And do we need to consider other ways of reaching people who may not be having access to some of the systems that are being used for the messaging? So that's my first question. My second question is in relation to care homes, and I think I read in some of the communications that support was being provided to the care homes to try and alleviate the pressures that are being felt. So I'd like to know a little bit more about what support that was, and did it have any adverse effect on what was happening elsewhere if resources were being diverted to support the care homes. Thank you.
Okay, thank you very much. But so we can take the first part about communications. Who would like to come in on that?
John, I wonder if June might just give some of the context. June was our executive director on call over the weekend and was, right up the middle of that. So I think some context from June would be really, really helpful to start that conversation.
Thanks, Adam. June?
Thank you. Apologies, I was trying to put my hand up, but it wouldn't switch on. So yes, so our communication went out via social media channels. So in this instance, and we have done this previously, we work with our corporate communication team, whoever's on call, and we agree a form of words that will go out on social media. And the ask was people who did not have an emergency not to come to ED at this point in time, and use the other channels for seeking support, NHS Inform, 111, or go to their GP or at the beginning of the week. So that communication went out, and I say it went out via social media channels. I'm not sure Stuart wants to say anything about any other forms of communication that we could use in the future.
Okay, that would be helpful, Stuart, and maybe pick up on Bert's part of that question about how effective we would evaluate it to be. Stuart?
Yeah, happy to do that. I think it's important to reflect that communication is kind of on a number of fronts. So that first, there's a prevention message, supporting people to sort of remain well, before they become acutely ill and require admission. There's also the direction, and I'll say direction rather than redirection, that Adam was referring to around the know who to turn to, because often there could be more appropriate settings than an emergency department for certain conditions or yes. And then thirdly is the, when the pressure becomes described, what can we do to support colleagues in the ED, and potentially to advise people of long waits before they make a journey into hospital, to perhaps consider calling 111. And I think there's anecdotal feedback that some people actually could have been supported within their own home, and rather than sort of endure a long wait in an ED department. So it's kind of from an experience point of view, that's quite poor. But equally, if you could actually speak to 111 and be treated at home, then that's far more better experience, isn't it, for patients? So it's kind of a three-pronged approach on that front. But I would echo sort of Sandra's points about the fact that the people who are presenting are older and more ill. So there's little we can do if we have sort of 2 years of unmet need coming through the front door. We need to kind of obviously make sure that the system is as efficient as it can be, and I think obviously that'll be described later in the meeting. Thank you.
John, could I maybe come in with a comment? Would that be okay? John, so thank you very much. I think what Stuart's alluding to is really, really important, because obviously in the moment, communication has got lots and lots of challenges in terms of both the message and how you deliver it, which emphasises that going into the winter period of time, we need to have further refresh of how we approach our sort of standard know who to turn to campaign. And I think there's a couple of reasons for that. Is one, that it's undoubtedly the case that our healthcare system, particularly around unscheduled care, has had a number of significant changes over the last couple of years, which have been pretty dynamic, which is pretty difficult for people to know exactly where we are. So that's the first thing. And probably the biggest feature is that it's probably become more complicated. And so we've got a job in terms of making sure it's simplified and the message is simplified. I think the second thing is that one of the areas that came up with our public health colleagues, which I think is really important, is that one of the fallouts of economic pressures in society is that we probably pull in a bigger group of people into what we would traditionally call our vulnerable groups, who haven't found themselves in that position before. And that's possibly a group of individuals who are less used to navigating the health and care system, and therefore we've got to think about how we communicate to a group that's now vulnerable and is, if you like, healthcare and system naive to how our systems work. So I think it's a really good question. It's really important that that's a big element of planning for the winter time.
Okay, thank you, Nick. And I see that Anne Bell has put something in the about other people who aren't on social media. So, and you were saying, Nick, about how do people in 2022 access healthcare? So I think from the board's point of view, if these issues are being dealt with, then we can welcome further updates as we go forward. Can we move to Bert's second question about care homes? Is that something for June, please?
Yeah, thank you. I'm happy to come in that one. So there were a number of care homes closed over the weekend, and these are for a variety of reasons. Particularly, Susan's here from her health protection team would have supported that, given there was varying infections. It could be flu, it could be COVID, it could be norovirus, varying reasons for that. As well as other reasons, the local authority have maybe put a stop on admissions to those care home environments. So that would be the reasons why. From a staffing perspective, my understanding is there was no issues over the weekend and no support going into them as such from the Health and Social Care Partnerships. However, we do have, if you think back to 2021, we got some money from Scottish Government particularly to support our care homes and how they deliver their care and support them with looking at IPC standards, etc. So that work still goes on, Bert, and we have our care home support teams in each of the partnerships who meet on I think it's still twice weekly basis as a whole system with and have an care home oversight group, which feeds into my enhanced care home oversight group. So we have a lot of governance, if you like, around care homes and the support that we're providing. I hope that answers your question.
Yeah. Okay, I think so. Bert, can we move on from that? Yeah. Okay, thank you. Sandy, can I bring you in?
Thanks, Chair. I have to say I found this extremely helpful. I mean, firstly, you get a very strong sense of the pressure that's on the whole system. But I think what has been really helpful today, and given that there's a lot of, I'm sure, members of the public, carers, families, maybe listening to today's meeting, we're not just simply having a description of the performance and the pressures in the system, but also some of that, a strong sense of what's been done about it, which I think is really important. And I particularly like, Nick and Sandra's input in relation to the planning that's going in, but what the different components look like and how that actually might make a difference in terms of helping people through the system. And I really liked the sense of the test of change that Sandra outlined, because one of the big problems for the public just now is how to access and how to navigate services. And I think the more that can be done to redirect people to the right people at the right place at the right time will make a significant difference, because many people are anxious about that. So really welcome in advance of winter, given all the pressures that we're under and given the pressures that we're likely to face, that some of this detailed planning and actually system change is beginning to take place. So very welcome.
Thank you very much, Sandy, and that assurance that we're seeking in terms of is the necessary work taking place around this. So thank you. Can I go to Luann, please?
Thanks, John. Two questions from me. One, I'm really thinking about, in usual times during the summer, there is a bit of a recovery period, but it feels like there hasn't been any let up in the pressures in the system for the whole of the last year at least. And I'm really thoughtful of staff and the impact that's having on people. It's really encouraging to hear the test of change that's been described by Sandra. And I just wonder how soon we could expect for staff to feel a difference in the pressures that are in the system currently. So that's my first question. And my second one is around the winter planning. And I really welcome how Nick described a nuanced approach where we recognise different people, different communities will be impacted differently. And as much as it might not feel like it, winter isn't here yet. And I wonder what conversations we're having with community planning partners to ensure any action that can be is taken now to prevent illnesses that we know are associated with poverty. So, you know, heat in homes and access to affordable food and those type of things. So interested to understand what our conversations have been with community planning, but really appreciate the update. Thank you.
Okay, thanks, Luann. I think your first question's then directed to Sandra about when can staff expect to feel a difference?
Thank you, John. It's a difficult question to answer, Luann. I think we would hope to see impacts, changes every day, but I'm not sure I can give you an answer. Sorry. If it's about the impact on the test of change that we're doing, you know, we already seen an impact on that yesterday, so that was there. We've got less pressure on our system today than what we had yesterday, so that's already having a benefit. But I think as Nick described it, there's and as has been outlined, there's lots of different parts of the system that are under different kinds of pressure. It hasn't felt like we've had a respite over summer. I would absolutely agree with that. From a staff perspective, it is just about encouraging people really to make sure that they're taking their, you know, taking their breaks, taking their holidays, making sure they're taking their days off. It's all of those and looking at simple wellbeing measures. I know that Tom, for example, in the, you know, We Care programme and things that's fundamentally about looking after our staff. So I can't really give us an answer as we've got trajectories, we're planning for that, we've got milestones, those are all being worked on, so we should have a clear direction of travel about improvement, but to give an actual, this is when we should see the data. Apologies, I'm not sure if any of my colleagues would like to support that, or if there's anything else they would add or a different opinion.
Well, first of all, Luann, you've heard the response to that. Did you want to come back on that, or do you want to note that at this point? I see Susan's wanted to come in as well, but Luann first, did you want to come back?
I suppose it was just, I think it's the totality of all the different interventions that will add up to positive change. So it's just whether is that 6 months away, or is it, you know, I think Sandra's maybe given a different answer that actually it's happening immediately, but it's the totality of that will improve gradually over the next few months. So that was what I was meaning, really. It's just a sort of ballpark of timelines.
Okay, thanks, Luann. Susan, did you want to come in on this?
Yes, it was just to pick up on Luann's question around community planning. So I guess the short answer to that is yes, we are connecting in. There's a huge range of services and support available. The challenge is ensuring people are clear about how to signpost individuals on to get the support that's relevant to them. So at the moment, we have connected, for example, our income maximisation, so our money advice support is being embedded in our Making Every Opportunity Count. There is a benefits app that was developed by Aberdeen City Partners, and again, we've taken action to ensure that our staff are aware of that and can signpost and support people to use that if that is appropriate. So work is underway about our winter wellness plan, which is the more preventative upstream actions, and that will be part of the tactical plan as outlined by Nick.
So just trying to come off mute there, sorry. Thank you very much for that, Susan. And Nick, would you like to come in?
Yeah, I guess I'll just build a little bit in support of Sandra and Susan as well. So I think you're absolutely right, Luann. There's definitely going to be no one thing that relieves the type of pressure we have. And so it will be about what are the collection of things that hopefully relieve the overall feeling of heavy system pressure. I also think that there's quite a bit that the better we organise ourselves, the more clarity we have about our plan, the more engagement we have about that, those offer positive support to our staff and to people that we are there with them trying to work our way through. So there's a value in that, as well as the individual value in improvement efforts that are made, and those things together hopefully will allow us to stand by staff to support what will still be incredibly challenging. We definitely aren't of the belief there's one fix that's going to suddenly switch off pressure. That's not the case. It's a very, very complex picture, as you allude to.
Okay, thank you. Tom, would you like to come in?
Yeah, sure, John, and not wanting to try and oversimplify this at all, but just reflecting on what Susan was saying and Sandra and Nick, I think we're really acutely aware of the fact that our staff are citizens as well and are facing pressures outside of work at the moment, like a lot of us are, as well as in work. And so, you know, we've been exploring ways in which we can, for example, support them with the cost of living challenges, you know, looking at a discount scheme that will enable people to access discounts in kind of key retailers, which is hopefully helpful to some of their underlying costs in terms of living their lives, but also in the workplace, the We Care programme that Sandra alluded to. I think it's notable we've had some real success in spreading the peer support approach to support a mental health first aid approach, if you like, across. There are certainly 43 staff trained across 11 departments at the moment, and with another 5 departments coming on stream and have had staff trained. They're coming on stream in October, and then another 2 booked to train during October. So again, we know that that peer support is a really key first stage in supporting people with some of the challenges, both of work and life in general, and we hope that that's going to continue to grow and strengthen, I guess, as we move through the winter.
Okay, thank you, Tom. So, Luann, I think we've dealt with the staffing part and the winter planning part of that. Are you content with that, the response on that part?
Yes, thanks, John. It's just important that we're connected with community planning, and Susan has outlined that. Thank you.
Yes, okay, thank you. And it does highlight the complexity of this, but also I think I'm encouraged that we're thinking ahead into the way Nick was talking about. We're still paying attention to education and training for future capacity, etc. Okay, can I now move to Dennis, please?
Thanks, Chair. I think first of all, I probably should begin by saying that I welcome that there is a recognition across, I think, all sectors within the Health Board and the Health and Social Care Partnerships that it is a very complex system, and it is one that seems to be like a sort of one system approach, which, you know, I think is extremely welcomed, because there maybe was a disjoint in the past to some extent. But I really want to pick up a couple of things that has been mentioned already to some extent, and you know, I think Luann was sort of looking for an answer from Sandra, but the thing that strikes me at the moment is the pressure on the delayed discharge across the system is impacting on what is happening within our community. And although we've got this test of change and, you know, hospital at home and, you know, the other initiatives that are taking place, the one thing that I'm not hearing is the additional resource, because we have an existing staff group which is under an immense pressure, but within our health and social care system, within our community, if we don't increase that staffing and the resilience and the sustainability, then, you know, the plans that Nick's alluding to, and I think that June's highlighted, and Sandra, that it's not going to happen, because, you know, we can't make it happen because we want it to. We have to put something there to enable it to happen. And what I'm not hearing at the moment is, how do we enable that in terms of our existing resource, but in terms of how do we actually recruit and have that sustainability for the future? You know, and that's still in recognition that, you know, it's a very complex system, and I think we've got to, you know, really commend the work that our staff groups are currently doing, given the significant pressures. But I'm just wondering if perhaps Sandra is maybe the best person to maybe answer the question initially, because it is about that sort of what we do within the community, and how we try and resolve that. Thank you, Chair.
Thank you, Dennis. And I suppose what that feels like is all of that work, if it's not dealing with a critical element, is going to keep coming back to us, and we're going to have to keep redoing that. So, and not to make it too simplistic, but that key question, who would like to come in on that?
I can come in, John.
Okay, thanks, Sandra.
So it's just really to say that the focus that we've described in the areas around urgent care, that's only one part of the, I suppose, one part of the puzzle. Each of the health and social care partnerships are working on their surge plans as well. So all that isn't around recruitment, it's around increasing social care, it's about looking at new models, it's about working with our voluntary and third sector colleagues to see how we can really focus on, building our communities. And I think, as Susan had highlighted earlier, community planning, working with our community planning colleagues. So that work is underway as well. I think the lens that you've got today is about the lens from the immediacy, if you like, of the impact that we're hearing about at the front door and there. But all of that work has to carry on at both ends of the system. So primary care colleagues, our GPs, and the different everyone who's engaged around primary care, as well as then looking at our social care. The whole system is connected on a daily basis, and there are plans in place for there. I think the document that Nick's alluding to will have clear sight of and will identify how all those links and those connections are made. We're looking across the whole system to see if there are any gaps, because you're absolutely right. If we don't keep an eye on the front door and the back door, if you like, all parts of the system, the risk is that we just keep going round in circles.
Okay, thank you, Sandra. Dennis, does that give you some assurance on that?
I mean, I hear and I accept and I'm acknowledging what's being said, but again, I come back to the pressure that we've already got, and it's each individual, for instance, health and social care partnership and each individual IGB have got their sort of strategic planning going on. But what I'm not convinced of, Chair, is that in the immediacy that is going to make that significant difference that we're hoping for, because again, I just come back to the fact it's about resources, and I'm not aware that we've got maybe in the planning, but in terms of redressing that immediacy, that initial, how do we resolve that delayed discharge within the community and getting people back into their homely settings? If we don't have the resource, we're not going to meet the objective, and that's the area that is still, I think, of great concern to me. That I'm not sure that one part of the system, if it's not going to respond, then the other parts of the system is going to be even under greater pressure. Thank you, Chair.
Okay, thanks, Dennis. And I think that's where the different, as you say, different parts of the system, there needs to be scrutiny of that, and it's how we then can join that up for the relevant assurance, whether it's at this meeting or in the health and social care partnerships, or together indeed in going forward. What I'm going to do, we've got 2 more people to come in, because I'm mindful that we want to also deal with the finance aspect. So I will bring those 2 colleagues in a moment, but I'll just rehearse what I'm thinking of in terms of the recommendations around this. Is that in relation to the performance targets that we have, we're not assured that those are going to be met, but that would be unrealistic in the short term. But what I'm going to be suggesting to the board is that we are assured that the necessary work is underway, and that progress can be maintained. But we've also highlighted a few aspects around staffing, the whole system working, etc., that we would like to have incorporated in our future updates. So I've just rehearsed that, and I'll come back to that in a moment. Can I go to Derek now?
Thanks, John. I would just endorse what Dennis has said. and endorse just what you have just articulated. I think it was very interesting hearing from Paul about things that are being done and seeing yesterday the conveyancing rules that are being put into place and apparently having a good impact. That's reassuring that things are being done to help. I do have 3 questions really. One is, people are turning up with greater acuity, and I wonder why, and is that anything to do with responding to the unmet need? So is the unmet need creating more people turning up at the emergency department? Second point, we've hit a wall, particularly there at the weekend, and we understand why about the discharge and the care homes and all the rest of it. But what I was wondering was a comparison with other areas. Are we a particular outlier, or are other areas in the same sort of region as we are? And the third part that crossed my mind was people arriving at the ED with issues that can be dealt with elsewhere. Would us being able to provide greater access to GPs help resolve that? Because people are phoning up the GP and being told to wait 2 weeks for an appointment. If that was not as bad a situation as it currently is, if we could improve that, would that help the emergency department? Thank you.
Okay, thank you, Derek. Can I ask Nick to come in on the acuity question first?
I'll start on that. So I guess, Derek, it's pretty complex, and I guess there are lots of views rather than a definitive answer. So undoubtedly, some of this does relate to what you could call the backlog or that has occurred through systems being paused and delayed. So there is an element around that. There may also be an element around the whole environmental situation that's been generated through this period of time. The disruption generates a degree of stress, and we know that those degrees of stress, as an example, going through winter, which has many of those features, generates health outcomes which are adverse. So whether that's mental health outcomes, cardiovascular health outcomes, so we'd see that. The third aspect is that chronic disease management probably is one of the areas that had quite significant pausing through this, and there may be consequences to that which are very difficult to pin down on. So to give you a type of example, we've seen a slight upturn in, for example, stroke presentation, and then that runs the question about why is that? Is that because of we know some of the acute circumstances that generate acute stroke presentations, but we also know some of the chronic disease management things that reduce the risk of having a stroke, and what are the factors related to that? And I know the stroke team are analysing that. So certainly in the areas of cardiovascular disease, stroke, some areas of malignancy and mental health, we've seen changes in the profile of what's making our population unwell. The other issue is the anecdotal thing that at the point of presentation, people are more unwell. And again, I think it's most of the data points to that is a real factor. Exactly why that is, and again, whether it's a delay in people being able to seek attention, or whether it's because of the patterns of sort of healthcare we've got, again, we're not sure. But those definitely look to be some real features. And the analysis of this, started when we started looking at excess mortality in the community, which was first identified in COVID, where we saw in the first year most of that was associated with COVID, and in the second year it was mostly associated with cardiovascular, liver disease and malignancy. So undoubtedly that gives us some clues as to what's going on in terms of the health of the population. I know that sounds vague, but I want to avoid telling you that it's a definite one thing when it's definitely not.
Okay, thank you, Nick. But I think it gives us assurance that in terms of the seeking that understanding and the depth of it. So the other points about access to GPs, I suppose, is another angle on Dennis's point about what's going on in the community. And a final comment on that before we move to Joyce.
I'm happy to make a comment on that.
Again,
I guess this goes back to really Luann's question about what's going to make a difference and when are we going to see a difference. And I think it's absolutely the case that we need a whole system response in lots of different ways to try and come together to make a difference. Absolutely, our primary care colleagues are involved in that. They absolutely are critical. They actually have the majority of the numbers of care episodes occurring with them. They're under immense pressure as well. So it absolutely is in the mix about how primary care, general practice are involved in responding to our urgent healthcare issue, our emergency healthcare issue, and our chronic disease management. So I think it's important. I'm just cautious about saying, again, a bit like answering Luann's question, is it one thing that's going to turn something? And the answer to that is no, it's not one thing, but it's absolutely in the mix, and that's important. And we've got very good, work. We work together with our general practitioners and our primary care colleagues across the whole partnership.
Okay, thank you, Nick. And the third strand that you had, Derek, about other regions, I think I'll just offer something on that, and then if Adam wants to add to it, he can. But from a chair's perspective, there is contact with what's happening nationally, and so whilst some aspects of what happens in Grampian are unique to Grampian, the same pressures are sitting there across the various boards, and all are grappling with that in a similar way. But Adam, did you want to put any detail on that at all?
Yeah, so Caroline being on holiday, I attended a board chief executives meeting just this week on Caroline's behalf, and lots of boards, not all boards, but lots of boards are in very, very similar positions to us. Some of the metrics that are shared confidentially across that group show very similar challenges across the country, right across the central belt, up where we are, coming right up the country. So I think there's a real sense we're not on our own. We're facing very similar challenges to other parts of Scotland.
Yeah, thanks, Adam. And clearly learning from each of the areas is shared as well in terms of going forward. Okay, can I move to Joyce for one final input on this, and then we'll move to the finance part. Joyce.
Thanks, Chair. I'll be as brief as I can. Also welcome everything that we've been told today. It's really comforting to hear that there are things happening that are making a difference. The test of chains are working. I have a couple of things I'm concerned about. Are we sending out sufficient communication about prevention, about preventative measures, what people can do to look after themselves, and about the fact that people are going to have to be more self-reliant in future, that there's not going to be a huge system there, as there has been in the past, to take care of everybody, that families will have to take care of themselves and everyone within it. I think that's really vital for the future. Linked to that, are we working with whoever's running 111? Because I'm concerned about the waiting times on that and how that contributes to people coming into ED when they've been waiting for an hour and a half on the phone and still have nothing else. So they will come in rather than hanging on any longer, because usually they don't call unless there's something that they consider serious. And finally, the issue around the cost to people who are sitting waiting on phones. If they are in an economic situation where they are vulnerable, do they have time to sit around like that? Is it, it's quicker for them to go somewhere, take somebody somewhere, than be sitting doing nothing on a phone. So are there other ways that we can help to get that message out about where to go, to the right place at the right time, quickly and efficiently, so that people are more confident in what they're doing. Thank you.
Okay, thank you. Susan, would you like to come in on that point about comms around prevention and self-reliance?
Yeah, so we have a plan that we're working with all of our partners around communication about not just about what people can do for themselves, but also the support that is available within communities to support individuals who might need a support to be able to look after themselves and keep themselves well at home. We're working with third sector colleagues at the moment, because what we don't want to do is send out a number of messages and not be clear around the pathways and the support, and therefore it's work in progress, but absolutely it is our intent to increase the number of communications that we have in place over the run up to winter. In terms of the partners that we're working with around communications, again, from the ComCell, and Stuart may wish to come in on this, we are actually working with NHS 24 111 to make sure that there is no wrong door for our citizens, so that we are clear that our know who to turn to has the right advice, and we are making it as easy as possible for individuals to get the support that they require from the most appropriate service that is available.
Okay, thank you, Susan. Adam.
Thanks very much, John. I just wanted to add a comment really on part of Joyce's questioning about, I think Joyce framed it as, you know, the reliance and people needing more self-reliance. I think we're on a journey for that. I think it's part of a transition over time. So I think we've signalled that in the plan for the future and the sort of work we want to do with people, with communities, and with self-reliance. So something in both people, places, and pathways. I think across all three domains, there's something about that change in the provision of support through health and care. I appeared at a parliamentary committee last week to speak about winter planning and winter preparedness. And I was asked a question about what might the government do, and I think it's absolutely related to this. Is you know, I believe that associated with this, we need a different conversation as a society about what we do and what we expect. And I think lots of that is really well guided by lots of literature. One of my current reread favourite books is Atul Gawande and Being Mortal, and that absolutely looks at that philosophical view of how do we deal particularly with old age and the use of healthcare and healthcare models and medical models. And I think that's the journey we need to go on together with our population and our citizens. I think it's very difficult to make a very sudden and dramatic change on that, and I think part of our responsibility is to have some leadership there and have a journey along with politicians and all parts of society. So it was just a comment, John, on that.
Okay, no, I think that's very helpful. Certainly one I would concur with myself on that. Just to finish this off then, we had a question about 111 there. Is that something that June or somebody could come in on?
I could make a comment.
Yeah,
if that's any good. Oh, so I guess the comment I'd make is that absolutely we're in dialogue with the organisations, because the healthcare organisations are involved in 111. So whether that's in the national chief execs groups where those individuals come together to talk about services, or whether it's I'm co-chair of the Scottish Association of Medical Directors, where we talk weekly with the medical director in 111. They're part of our group, so they're part of our system. And so I absolutely very much in the same way that we have Scottish Ambulance on our system calls, We have very regular dialogue with 111, and again, it goes back to that very, very difficult question: is that this is an issue where this is a complex problem where there are issues everywhere, and managing that tension of not sort of looking over the fence and saying it's all over there. It's actually, how do we jointly work around that? So a lot of those conversations about how do we wire our systems into 111 to make that very effective in terms of individuals getting directed to the right place. And that relates to how our Flow Navigation Centre links into 111, how do our general practitioners work into 111, and the number of support lines. So that type of dialogue does happen on a pretty national basis and pretty regularly around that. So hopefully that offers a bit of reassurance around that.
Yeah, thank you, Nick. Adam, did you want to come back in? No, okay, that's fine. And I think that final part about the costs for people kind of sitting on phones, etc., is about that access element that was touched on. So I want to bring that part to a close just now. I want us to move on to the finance aspect and bring in Alex to give some comment on that before we move to the recommendations. And I know I've gone over time with this, but I do think it's probably a really critical agenda item today. So Alex, can I bring you in, please?
Thank you, Chair. So as you can see from the dashboard, we're currently forecasting to overspend by £30 million at the end of the financial year due to the sustained operational pressures being faced by services and inflationary cost pressures. The Chief Executive team are taking this very seriously and have recently approved a local value and sustainability plan to help recover the financial position to the level outlined in our 2022-23 financial plan over the remainder of the financial year. This plan will be reported through the board assurance structure in October, specifically through the Performance Assurance Finance Infrastructure Committee. Once evidence of delivery of the plan is demonstrated, it should be possible to reduce the level of projected overspend. However, we need to bear in mind that we're still to experience the most challenging part of the year in terms of demand for our services. One point I would like to specifically bring to the board's attention is the reliance on non-recurring savings in the Value and Sustainability Plan. These savings will not be available in the financial year 2023-24, and we will be required to make additional recurring financial savings to replace them. In order to support the organisation in this task, it's been agreed to bring forward the budget setting process for the financial years 2023-24, and I've also arranged for the board to be provided with regular updates throughout the budget process. Chair, that was all I was going to say in relation to an opening, but I'm happy to take any questions, and over to you.
Thank you, Alex. Any questions for Alex on this? I think it highlights just the whole issue there about capacity and need, and on this side, the squeeze from the finance side as well. Derek.
Thanks, John. Looking at the graph, Alex, the green line is the forecast, the blue line is the actual, and they're pretty much following the same trajectory. So the blue line is below the green line, which means that we might actually be a bit over the 30 million. Which itself is 10 million over the budget. How optimistic is it that we are going to be able to get back on track? Is it overly optimistic? I know you've got this value plan, but given that we've had difficulty in achieving savings in the past, how optimistic are we?
Yeah, I think that's a really good question, Derek. I mean, I think if the status quo maintained, we would be there or thereabouts. We normally see some improvement near the end of the financial year as things start to, you know, if there's a spend still to be delivered and so on. But I think we do have the value and sustainability plan. There's a number of actions within there that are not factored into the forecast yet. and once those are factored in based on what we know at the moment, then we should be able to reduce the forecast. There's a number of risks as it sits at the moment. I mean, things like pay award not being finalised for the year yet. I've talked about winter, and there's been a lot of talk about that already in terms of the additional costs that may come along as a result of that. But we're monitoring and managing that as well as we can. It's very difficult to say at the moment whether we'll be able to come in on the £20 million due to the level of uncertainty within the system. But certainly, based on what we know at the moment, we have got a plan in place to bring us down to that level.
Okay, thank you, Alex. I don't see any other questions on this aspect, and we are, as you're saying, Alex, going to be getting input to the performance committee, which I think Sandy's on the 19th of October. So that's pretty soon, and they will be looking at this, the finance aspect on behalf of the board. Okay, so thank you to everybody for the inputs around this item. Can I take us to the recommendation, which is on page 15 of the pack, where we've undertaken the review and the scrutiny that was noted there, and noting that the system challenges in meeting those objectives, but I think also the targets that there are around the various waiting times, emergency department times, etc. So that's all a work in progress. The key element here is the board today assured that all is being done towards meeting the objectives as best we can. So I think that's the critical part on this. I would also want to add in a specific part to the minute of acknowledging the work that's going on through the system leadership and through all the work teams that are involved in this. So on that basis, is the board happy to go ahead with the recommendation and the way that I framed it? Okay, thank you very much. What I'm going to do, I'm going to actually bring our comfort break earlier to this point, and I'm going to reduce it to 10 minutes if that's okay, because that's been quite an intense item, and so we can just clear our heads and get a comfort break and then come back to pick up on item 6. So I've got it 11:23. Could we come back at 33 to start again? Thank you very much. Okay, that make it, that's just coming up to 11:33. So we'll kick off again. I think that's just about everybody back. If I can, that's it now. Yeah. So if I can pass on for item 6 to Paul Baku, Acute Medical Director, who is overseeing this project. Paul, would you like to start?
Thank you, Chair. Colleagues, the paper that we've enclosed in the document represents an update. It's an update to the board on our commitment given at the last board meeting in July. In particular, it relates specifically to the preferred place to build the NTC Grampian facility. The preferred place is currently known as the Estates site on the Forester Hill complex. Hopefully, you will take note of what we consider to be a comprehensive and detailed examination formed by the team and stakeholders since July. The papers attached describe the systematic and validated process which has been used by the team and stakeholders to process an initial list of 32 places across Grampian to one preferred place. As described in some of the papers, a number of criteria have been used through a three-stage process. At this point in time, we acknowledge that a number of challenges remain and that we will address and resolve those challenges during the next phase of the journey to delivering an NTC Grampian for the citizens of Grampian during the outline business case. So at this point, what I'm going to do is to hand over to Jerry Donald, who is our Head of Property and Assets Development, who's going to spend a little bit of time taking us through a bit of the process and the methodology. We're then going to hand over to Gary Mortimer, our SRO, and at the end, Chair, Mr. Gary will then direct questions as appropriate. So thank you very much, and over to you, Jerry.
Thanks, Paul. Thanks, Chair. Good morning. Gary, I think we can just move on to the next slide, please. So the purpose of this part of the work is to give you some assurance that we've been through an appropriate process, a governance process that's fit for purpose. We were set a brief for the site, which is much better, more succinct and much clearer than the one that we had previously. So we're looking at Aberdeen City, the Western Peripheral Route area and the commuting suburbs of Aberdeen, and Elgin as well. A two-storey new build, no refurbishments, no repurposed buildings this time, just new build. 8,000 square metres of build. It has to have future expansion space. It has to have car parking. The site size required for this is a minimum of 4 acres up to what we think is about 7 acres. It requires good accessibility by car, by public transport and by cycling and walking. It has to take into account inequalities, and it has to identify 3 site options for the option appraisal workshop. Next slide, please. So we commissioned an independent company to identify all the development sites available that complied with our brief. The return was 27 site options, as you'll see on your screen here. In addition, we identified 5 site options, a further 5 site options on the Forester Hill campus. So in total, as Paul said, we fully assessed 32 sites based on the brief set. Next slide, please. You've moved to there, Gary. Thank you. So having identified the 32 sites, we then went through an established process and identified some site-specific criteria to assess each of the site options against. And you can see those on the left of your screen. Having identified the criteria, we then weighted each of the criteria in order of importance. As you can see on the right of the screen, 10 is the highest and greatest importance. Next slide, please. Each criteria was then weighted either 2, 4, 6, 8 or 10, with 10 being of greatest importance. Then each site was scored either 2, 4, 6, 8 or 10, with 10 being the optimum score. Finally, the criteria weighting was multiplied by the score and a total score derived for each site option. Scrutiny and sensitivity analysis was then applied to each criteria to ensure each of the options had a form of consistency. Once satisfied, the 3 highest scores were identified as the 3 site options in front of you today. Next slide, please. This slide shows you the 20% most deprived areas in Grampian, with the deprived areas coloured shades of grey and red. As you can see from this map, there is deprivation scattered throughout Grampian, but more so in the larger towns and settlements. And there seemed to be a corollary between the size of settlement and the amount of deprivation. Next slide, please. This aerial picture, apologies about it, we seem to see more of the North Sea than I'd hoped on the screen. It shows Aberdeen out to Inverurie with all the site options highlighted in yellow. Apologies that the Elgin site at the east end of Elgin is not on this slide, but had it had been, then it would have been even more difficult, I think, for you to view today. Next slide, please. We now zoom into the Forester Hills site, showing the 5 sites that were considered for the National Treatment Centre, and also this aerial shows the adjacent Rayden site, which is very close to Forester Hill, and Rayden will come on to in due course. Slide 9 is next slide, please. This slide shows the last 2 sites we were down to at Forester Hill, with the Shale car park coloured white and the estates office site coloured red. But more importantly, it is to understand the constraints and development opportunities of the Forester Hills site. The campus has grown significantly in recent years. Much of the site has been developed, with few remaining sites being left to link in with the main clinical core of Phase 1 and Phase 2. The area bordered yellow is the last remaining area that can link in with the clinical core, and we have therefore reserved this for services that need to be on the Forester Hills site. As per the brief, the NTC Grampian does not need to be on the campus. The area outlined in purple to the right of the screen and adjacent to the red area is reserved for a new roadway to support the east end of the Forester Hills site. Smoothing some of the bends and tight junctions that exist there at the moment, and this will be possible after the Baird Family Hospital opens and the demolition of the maternity hospital is complete. Thanks. Next slide, please. These are the 3 sites from the long list that we drilled down to, and we'll further explore them in a little bit more detail. Next slide, please. So at the workshop, all present were asked to make some assumptions re the NTC Grampian. A new build comprising of 2 stories. Why 2 stories? Well, that's because we maximise our use of space and clinical efficiencies. For example, endoscopy and day surgery being able to share a floor, recovery area and staffing. The new build will be 8,000 square metres. It requires 7,500 square metres for the build itself, but we then have the net zero carbon compliance matters, which increases the size of the building to around 7,500 square metres plus. So we just rounded that up to 8,000 square metres. There needs to be future expansion space. 250 space car park on site for patients and staff, so all options have parking. The site ideally should be no less than 4 acres, perhaps as large as 7. It must have good accessibility to public transport, walking, cycling and car. Must take into account inequalities, must comply with health building notes, which we refer to as HBNs, and assume any derogations are likely to apply to all 3 sites. Next slide, please. So here's the first of the 3 sites in more detail. Here we have the Estates Office site coloured red, showing its location on the Forester Hill campus to the east end of the campus and close by to the corridor reserved for the new road outlined in purple. Next slide, please. Sketches to the left of this slide are indicative of how this site may be masked, and I stress indicative. The site is just over 4 acres, but provides little or no room for expansion without displacing some other services or buildings nearby. A new multi-storey car park will be required to support the National Treatment Centre at the East End, and also the other buildings such as a new anchor unit and all other East End clinical services. There are some support services nearby, such as a hotel. We brought that into consideration as well, at Kingsgate and Langstrath. As it is on site, there will be limited supporting accommodation provided for in this building for catering, staff welfare and facilities management. Nearest public transport will be at Cornhill Road, but there's plenty of alternative transport options at the front of Phase 1. where there are regular bus services. This site does have occupied buildings which will require to be relocated before demolition, but we believe that that can be completed to allow the NTC Grampian construction to begin, and it can be completed in tandem with the detailed design and planning consent. So I don't believe it adds any additional time onto the opening of the NTC Grampian. Next slide, please. Moving from the Forester Hill campus across Westburn Road to the Raid End site, and I showed you basically where that was on the previous aerial. The site is largely owned by NHS Grampian, outlined in red, other than the walled garden, which is owned by the council. An attractive site, but potentially because of this, the most challenging site to deliver in a planning consent. Next slide, please. Again, sketches to left shows indicatively how the site could be massed up. The site is ready for construction. The site is almost 6 acres, including the City Council ownership, and the council are or were agreeable to selling the walled garden to the NHS. Because of the many mature trees on this site, future expansion will be limited. Again, there are support services such as hotels nearby, public transport, bus services runs on Mid-Stockett Road, parking provided on site for patients and staff, and supporting services would have to be provided on site, with this being off the main Forester Hills site. Next slide, please. Gateway site, the final site, the Gateway site, which is adjacent to Tekka, driving out of Aberdeen from Bucksburn towards Inverurie, you pass Tekka. Hopefully you can see that on the screen. On your right-hand side, and next on the same side, is a vacant field. That is the Gateway site, which is bordered by a road going to the airport. The site sits on the A96 and is adjacent to the A90 Western Peripheral route. Next slide, please. The site is 20 acres, owned by the University of Aberdeen. However, we believe that only 10 acres of the site would be permitted for development. The site is ready for construction. It's adjacent to P&G Alive and associated hotels and eateries. 250 parking spaces would be provided, well located for public transport and road linkages, and near the airport for island patients, but I stress not on the flight path. Final slide, Gary, please. So I hope from that you are assured of the thorough process undertaken to assess the 32 sites to arrive from 32 down to 1, and that those present had a good understanding at the workshop of what they were scoring and how they were scoring it. The Estates Office is the preferred site. Thank you. Gary, over to you.
Thanks, Jerry. If I can just be great. So thanks, Jerry. For board members, I really just wanted to talk about our next steps, and in particular the programme. What you see before you is a 4.5-year programme, and that does feel like a long programme given where we've been and how long it's taken us to get to this point. I would highlight on this slide that 50% of that programme is the construction and 50% of that is the remaining planning stages. At the top of the screen, you see what are described as the RIBA stages, the Royal Institution of British Architects stages that we need to comply with in terms of formal gateways. And you'll see that that evolves from a 1 in 500 scale plan that we will develop over the next 3 months, that will look at that site massing and orientation and roadways, etc., that Jerry described, through to 1 to 200 scale concept designs over the remaining period. And then at full business case stage, we take that to room level detail before going to the market. So quite a complex sequence. We continue to stress test this programme. We're working with colleagues at Government and Health Facilities Scotland to make sure that this is robust and realistic. An important factor that is new to the process, for us at least, is the introduction of the NHS Assure audits that happen at both OBC and FBC stages, and our estimates are that that's going to add another 3 to 4 months in each part of those journeys. Now, we're already working with NHS Assure to mitigate any risks that becomes further elongated, but they will support us through audits of our technical compliance, our sustainability compliance, and of course the design compliance. And you'll see that at each stage we will bring a paper back to the board before it goes to the capital investment group. So we'll continue to do what we can to pull this back, but we think at this stage this represents a realistic journey. Final slide is just given the pace, and I guess linking it to your previous discussion about capacity and pressure on the system, mindful of that need for pace and organisation and good governance, our proposal is to set out 8 task and finish work cells. There may be more, but 8 are the most obvious, and some of these will be very obvious. It includes the Dr. Gray's MRI piece of work. The others are pretty obvious. I would highlight 3 in particular. One is around workforce and education. We want to build on the really good conversations that we had with our education partners around how they can work with us to build some educational component to the National Treatment Centre. Also, a cell looking at interim capacity, building on your previous conversation, looking at what we might be able to bring forward in terms of NTC specialties, using some of our existing estate, looking at our regional National Treatment Centre partners, what we might do with them to bring that capacity on board before we have a building that's opened. And across at the right-hand side, doing anchor organisation. We spoke at the last board meeting about using this project as an anchor organisation exemplar. So really having a strong focus around that and setting that up as a separate cell. Part of that will be submerged in some of the other cells, but we think by having that as a standalone grouping, that will give it the level of importance and focus. So that's our process going forward. I'll pass back to you, John, or Paul, to field questions. Thank you.
Okay, I'm happy to come in and do that, Paul. So thank you very much. For those that are kind of listening in today, the National Treatment Centre in Grampian is part of a national programme of several centres across Scotland. And so the timing of this is linked, as the presentation indicated, to negotiations with Scottish Government around funding. What we're asked to do today, we're focused on the decision, which is the choice of the site. So I'd like the scrutiny that we have to lead us towards that decision. Can I go to Ian first, please?
Thanks, John, and apologies for not doing this at the start of the meeting. Given that Aberdeen City Council has a financial interest in one of the shortlisted options, I'm not quite sure what the terminology is in the NHS terms, but I think what I need to do is make a transparency statement to indicate that Aberdeen City Council has a financial interest in one of the shortlisted options and that I am a member of Aberdeen City Council. Given, however, that it is not the recommended option, I don't believe I need to withdraw. And I hope that Sarah will correct me if I've got any of that wrong.
Oh, thank you very much, Ian. And I think Sarah saw her nodding. Did you want to just confirm that, Sarah?
Yes, that's absolutely fine, and we'll note that in the minutes, Ian.
Yeah, thank you, Ian. That was good.
Thank you, and again, apologies for not raising that at the start of the meeting.
No, that's fine. It's perfectly legitimate to do it part of the way through if it comes to mind at that point. Thank you. Bert, can I go to you?
Thank you, Chair. A very comprehensive and very thorough approach, I think, has been taken, and the presenters have given us a very helpful insight. I've only one question. Part of the design brief, if I've picked this up correctly, is that the sites should be somewhere between 4 acres and 7 acres in size, and have a scope for future expansion. The site is identified, I think, as having 4.1 acres in size and has limited expansion, I think is one of the comments that's been made. I just wonder if there's, if we can get any assurance or further information in relation to what that means in terms of the potential for future expansion. Thank you.
Thank you, Bert. Is Jerry wanted to come in on that, or Paul, whichever?
I think Jerry should come in first, please.
Perfect. Thanks, Chair. Thanks, Paul. I think it's you need to set this into context, and perhaps I touched on it, but not enough, Bert. But the site and the surroundings are owned by the NHS Grampian and the University of Aberdeen. So the expansion space would have to come from the removal of other buildings around about it. I think as we begin to look at the longer term plan for the Forster Hill campus, there are other buildings there that are planned to be relocated subject to funding, and on the basis of that being in place, and we would require funding to extend the NTC Grampian as well, we believe that there is an opportunity to extend the NTC Grampian should we require to do so. You're right, it is at the bottom end of our minimum requirements, but there is scope there within the ownership to do that, I believe.
Bert, are you assured on that? Okay, thank you. Derek?
Thanks, John. We are asked, are we reassured by the process? I am reassured by the process. 3 points, though, that I'd like to make. The process is reliant on numbers, and the outcome of it was very close. I particularly don't like the number system. I do like a bit of judgment in there. So I'd just like to be reassured that the judgment agrees with the numbers, that people are, by their profession, agreed that the right solution has been arrived at by their judgment, other than just simply by the numbers. Second one is what happens to the estates. They have got to move somewhere, and we've said that a matter of time is not an issue. The issue might be one of matter of cost. Does that add an extra cost? And the last part was, I know we've got NHS assurance processes to go through, but did we include anybody from NHS Assure in the scoring process? Thank you.
Thank you, Derek. Paul, how would you like that handled?
Yeah, I think the first question, particularly around the process of using data analytics and judgments, I think we absolutely took a long time to weigh and balance the various inputs of information. And one of the things that was quite interesting was, you know, the voice of clinical teams around this. One of the advantages of being separated from certain areas of our estate, but within the footprint, is definitely the ability of staff being able to be used more efficiently, which then correlates and transforms into costs and recurring costs. And there was definitely an area there where there were advantages of being on the Forster Hill complex as the preferred option site at the estates, and the ability to use staff in those areas more efficiently. I think that was definitely something that came out through. And maybe Gary, you want to have a look at the second question, and maybe bring in Julie for the third question around costs.
Yeah, I'll maybe pass to Jerry about the estates relocation, or Paul Allen indeed first.
So I'll maybe come in on that one, Gary. So it's not just the Estates office, Derek, it needs to be relocated. There's the Baird and Anchor offices, and there's Grampian Hospital Radio. All three options, we believe that we've got locations to relocate them to. So that's not a major issue. And I don't believe that the relocation of those will hold up the overall programme for the opening of the NTC Grampian. I believe that can be done in tandem with the detailed planning application and the detailed design being drawn up. There will be a cost attached to it, there's no doubt about that, and I think Gary was alluding that Julie will come in and respond to that point. And perhaps there was also a kind of fourth point there to your question as well, which was around NHS Scotland Assure. NHS Scotland Assure weren't involved in the site selection because their primary area of interest is really in terms of how the building is designed, how it's laid out, and how it complies with all the guidance. However, I can confirm that our own infection prevention control doctor and team were around the consideration of these sites. Julia, perhaps pass over to you.
Yeah, Jerry, I'll just supplement you before Julie comes in. Just to clarify, Derek, NHS Assure, although they weren't part of the site selection, they were active participants at the scoring workshop appraisal in September. So they were in the room as we scored. Julie.
Yeah, just very briefly, just to assure the board that in terms of the costs of developing each of those sites, we did make allowances both for things like land acquisition and the relocation and decan of existing area. So that has been included within the appraisal and within the cost estimates. But as Jerry's indicated, we will have to work through that plan of relocating those staff and costing that in more detail, but provisions has been made within the costs presented to the board.
Okay, thank you, Julie. Can I bring Paul in, because that would be the bigger part of the relocation. Could you comment on that part, please?
Yeah, thanks, Chair. And just to come in and support what Jerry was saying there, so if you look at the Baird and Anchor project offices that we got, they are refurbed old buildings, porter cabin type buildings that were time limited when we got consent as part of the project. So that fits in with the timeline that's been put forward by colleagues today. So we'd be having to demolish that buildings at some point anyway. The other one is we've had plenty of discussions around the future of the estates office there. The buildings are not in the flushes of youth, and I think it's an opportunity around this project to relocate them. As Jerry said, there are options available anyway, and they're already being discussed. So that's two site locations there within that overall footprint that's already been planned for. The hospital radio is also what Jerry was saying is part of those discussions, and they've been involved as part of the process. But very supportive of what's been put forward today. Thanks.
Yeah, thank you very much. Can I come in with a question, which I understand that something on the Forester Hill site in terms of future revenue costs, and we've heard about the finance issues, and in previous board meetings, an external site would have higher revenue costs because of the staffing levels. So that seems to be a positive in terms of our future budgets, given the pressures under them. But I just want a bit more on the equalities issue. So it was kind of in that presentation, but I'd be keen that our ambitions about an anchor organisation can be taken forward in any new project like this. Could I get some comment on that, please?
I think that
John, yeah, I guess, I mean, being an anchor organisation, I think it means many things, many different things to almost everybody that we've spoken to. And I think there's a real risk that we do this in a light touch way and perhaps have, modern apprentices through a construction programme. We would like to do much more. We've talked about using this as an exemplar. There's a myriad of opportunities, both in terms of employment, but also in terms of sustainability and use of place. Some of that may or may not have a cost impact or a scale impact on the building. I guess the point is we need to work through what those opportunities may be and really be serious about that. So the proposal on my slide was to set up that group, and I guess a request to the board would be perhaps to have a non-exec or representatives from the board around that table to help us drive that agenda. If we're serious about doing that and doing it well, I think we shouldn't be tinkering at the edges. We need to be building that in right now as we work through the OBC stages.
Okay, thank you for that. And we can think about that offline a bit further, because there's possibly within the context of the whole Forester Hill site that review could take place. Okay, thank you. I don't see anybody else signaling on this, so we've scrutinized the process and then the decision here. So they're the key things. If I can take you to page 42 of the pack, where we've got the recommendation, and we're asked to endorse the proposed site as what's called here the estate site. Can I just go through that first? Are we content with that as a board? Okay, thank you. That will allow future outline business case to be brought back to us. So the and the project timeline we've seen, so we can note that aspect. So we can look forward to that coming back, and I think we can reflect on say the Population Health Committee taking a view around that anchor organisation aspect and supporting the work there. So are we content to go with those recommendations today? Thank you. And thank you for the inputs to Jerry and Gary and Julie there, and from Paul. Thank you.
Thank you, Chair.
If we can go to the next item, which is item 7, strategic plan for Dr. Grace Hospital, and Adam, over to you.
Thanks very much, John. Just a really brief intro, because we've been doing lots on this as a board. So quick reminder, at the plan for the future in June at the board, we made a commitment to create a strategic plan for Dr. Grace Hospital that really sets out clearly its role for the local community, its role within Grampian, and the networks that will support it to be extremely vibrant, working probably with both Highland, Raigmore Hospital in Highland, and Aberdeen in Grampian. So that's the sort of idea. The board's had lots of involvement and has more to come. So we agreed to do it in June. In August, you had an update formally at the board. In September, you had a workshop that included quite a lot of work about Dr. Gray's. We've got an update today. In November, the board are meeting for their seminar actually up in Dr. Gray's, and there's a number of visits around the hospital so that you'll see a number of things firsthand and meet staff. And then we'll have the a further update in December, and then the formal sign off in February. So really keen to emphasise for people beyond the board how seriously the board are taking this and how important it is for the board to really get this right, and how crucial it sees the role of Dr. Grace going forward. So in the paper today, it's really seeking that the board feels assured that the process we're going around at the moment to really get the intelligence is robust. So lots and lots of work happening with staff at the moment. The work with the wider population is underway, and really concentrating over the next month or so with a number of clinical colleagues supporting that work and supporting those conversations. Probably stop there, John, by way of introduction, and very happy to take any questions and comments on things that people are wanting to know about.
Okay, thank you very much, Adam. And this is very useful for each board meeting to get an oversight of this as you move towards a plan being produced early in the new year. Thank you. Dennis first.
Thanks, Chair, and thanks, Adam. Just a couple of points in the paper in some respects. At the beginning of the paper, you're saying it's an NHS board and integrated joint board, and it says strategy or direction. Which one is it? should it be strategy and direction? It just says strategy or direction, and I'm just wondering what it is. And I'm not particularly aware of how much input there has been to date within the IJB itself within Murray. There's lots of other meetings that have taken place, partnership meetings, community planning. There's been lots of other things, but I'm not entirely sure how much involvement in terms of that partnership with the IJB. And the paper's presented to us as, you know, you're presenting it saying, we're presenting this paper more or less telling us we're assured, as opposed to asking us if we're assured. And it may be just language. It probably is just language, because you're also seeking your assurance and endorsement. But it's just the way some of the phraseology within the paper is actually written. And I'm just wondering if you want to comment on that. Thank you.
Adam, would you like to come in?
Yeah. Thanks very much, Dennis. Having written lots of it, I will fully take responsibility if I've been clumsy in my language. I certainly wasn't telling you you're assured. I'm seeking the sense that you feel assured by what we're doing on your behalf. So apologies, Dennis, if that's been clumsily written. We're creating a strategy, so we're really creating the intent and the direction. And again, if that's clumsy in the or, it is a strategic intent for the hospital, and just to reiterate, that's really crucial in my mind to create a real sense for people that work there, what their role and purpose is over the next, I don't know, something like a decade. And similarly, it's really crucial for both the local population, but as everyone keeps saying, really, really important that the role Dr. Graves plays in the Grampian context and the work that it can do across the whole system. So it's all of those things. In terms of the engagement with the Integration Joint Board, Dennis will pick that up if we can with you, to come and speak to you. Certainly at an officer level, we've got a huge amount. Carmen, as the Health and Social Care Partnership Planner, is a member of our small working group. Simon's on the working group and has overseen lots of it. And as you know, it was the lead presenter at the board seminar about this work. So we at an officer level, we're really, really tied up. And if we could do a bit more with the formal Integration Joint Board, then I'd be delighted to do that, Dennis, and we'll pick that up going forward.
Okay, thank you for that. And just another point in terms of the engagement with the staff group. Again, I think the paper's presented in terms of the sort of positivity and indeed comprehensive engagement. My understanding is from being at the staff governance meeting that the engagement is maybe not as comprehensive as is being suggested, and the engagement isn't as full as perhaps we would like, and that's maybe just a perception from the staff perspective. Others may want to pick that up, that obviously members of the staff governance committee as well, but it's just that it is presented very positively, and I welcome that. I really do, but I'm just not sure that it's accurate in terms of where we are. Thank you.
Yeah, thanks, Dennis. And I wasn't at the staff governance committee, but Tom Power, Director of People and Culture, did say to me that there'd been some comment about a sense that it wasn't developing in partnership in the same way. We've certainly had lots and lots and lots of staff involved, and we've been in touch with Stephen actually before yesterday's meeting to try and get some formal partnership representation on our small planning group. So you know, that was a gap in formal partnership terms, but in terms of the engagement of staff, it's been you know, really good, both in the formal workshops that Louise Ballantyne's been leading for us. I think she's now completed 14 workshops with I don't know the number of people, lots of people. We've also had the opportunity for staff to contribute through the survey that's published online. We started off with a drop-in survey, which had 200 people or just under 180 people from Dr. Gray's. So I've attended their senior staff meeting every week, which has 40 or 50 people. I've met with about 20 or so people individually. So there is a huge staff voice driving this. It maybe not through the formal partnership line, but the staff voice is being heard absolutely loud and clear.
Okay, thank you, Adam and Dennis. And probably when we come to the recommendations, we can add something in to follow up what you're suggesting there, Adam, in liaising with Simon and with Dennis, but also Tracy as the chair, co-chair of the IJB. So thank you for that. Luann.
Thank you. I suppose it's good to see the activities that have happened. Where my mind went to was that our strategic intent as a board is to do consultation in a very different way to how we've done it previously. And I was just looking for a bit of detail about how we're not doing the old style, drive-by consultations as one-off events, but we're actually engaging on an ongoing basis with staff and communities, and we're doing a bit of a feedback loop about, well, this is what you told us, so therefore this is what we've done. So it was just to get a bit more detail on that, Adam, if that was possible. Thank you.
Yeah, absolutely, Luann. And so our timing, just to be really transparent, our timing between the staff and the public engagement is not ideal, I would say. And part of that was the time constraint that we put upon ourselves to do it. And we knew that from the very inception point in June. But as we all know, there was many drivers to try and get to a position rapidly. So our staff engagement started earlier than our public engagement, and we have designed in that iterative process with the staff. The public engagement is starting now and building from many local networks, including some of the more seldom heard voices. So that's absolutely happening. We will be going back in that iterative bit. I'm just conscious it will feel quite rushed. So again, that will be a bit of a limitation on how it's happening, and absolutely not the gold standard that we've been trying to set out. It will be good, but not the gold standard. And I think that's partly just to do with the time constraint. And again, just to rehearse that so that everyone's aware of it, including people who are newer to the board. We've got some external drivers around the maternity part of this, and the maternity part is absolutely driving some of the broader strategy. And we didn't want a huge gap between the maternity bit and the overall strategic plan for Dr. Gray's. That would just feel really, really clumsy in my mind. So that's part of why we're going so quickly, and that is meaning that we're compressing some of these iterative processes. So they will be good. I'm confident in them. I think they just won't be quite at the pace that you'd probably design it for gold standard.
Thank you, Adam. And certainly in preparing for the board previously, I had a discussion with Adam about the Population Health Committee, which will be coming on stream in November. And as a board, we've now become accustomed to that kind of what you're describing as gold standard around the plan for the future. So we can look at that going ahead for as things move forward, because it will be beyond February that we need to have that whole consultation going on. Thank you, Luann and Adam. Can I turn to Joyce now?
Thanks, John. Adam, when you're talking about engagement with staff, are you talking about the whole system staff or just health staff? Because I think this is where we identified yesterday at staff governance that there's still some sort of dislocation between various staff groupings. So I want to be sure everyone's included.
Yeah, thank you, Joyce. So we've developed the engagement with staff has been in two streams. It's been partly around staff groups and partly around pathways of care. And the pathways of care have intended to be more inclusive. And if they haven't been, I'll check that as we've got a full debrief on Friday with all the sessions running, so we can check that out on Friday and still got scope to close that. Certainly one of the early sessions was one of the early bits of planning was to make sure we had a session with primary care colleagues, again as one of those groups working with the hospital, but helpful prompt that we've still got time to you know, revisit any gaps that are there. So thank you, Joyce, for that.
Thanks. Can I just pick up another point that I find it interesting that we talk about a Dr. Gray's strategy, but we don't talk about an ERI strategy. We talk about NHS Grampian strategy. And I do realise it is a separate hospital, but it's still part of NHS Grampian. And I wonder if we are continuing the division that is certainly there and the siloing of aspects of the health board by splitting things off in this way, because I don't think we'd ever have an ERI strategy. Thanks.
Yeah, hate to publicly criticise you, Joyce. We did have an ARI strategy about 2 years ago, I think. So we absolutely did try to, might be 3 years ago, sorry, but quite recently, before Fiona retired, Fiona led through a really clear bit of work to try and understand the role of the hospital. But part of the value of it also works really well with sort of Jerry Donald's expertise and the facilities and the planning around the infrastructure and the work that Paul is the responsible director for. So and part of it, and part of the reason I'm really keen we have a concentrated bit of work on Dr. Gray's is that to some extent I think we've not given it enough attention, and maybe we need to just push the pendulum a bit further up to make sure that we get it in the right place. And again, some of my conversations with Paul Baku are absolutely about how do we keep, as you say, not in a silo, but that holistic bit. So I think you're right to point out the potential risk of it. I think it's a deliberate one that we're trying to achieve something, and part of that is also making sure we get the integration much better with Forester Hill, both ways, both from Dr. Gray's to Forester Hill and Forester Hill to Dr. Gray's. Those relationships need to be really robust and really keen, and that's part of what we're exploring in lots of the sessions we're doing at the moment.
Thanks, Adam. I'll take on board the fact I didn't remember the ERI strategy.
Sorry.
Thank you for that. And I think it is seeing Dr. Gray's as part of the networks that is really key as well. So I think that will come through as well. Susan, did you want to come in on this?
Yeah, thank you very much. And I guess it's just a point of clarity so that I'm clear in my mind, Adam. We were talking about Dr. Gray's in the context of the network, but when we were talking about engagement, I just wanted to check that we are engaging within that network around how the network sees the role of Dr. Gray's moving forward.
Yeah, absolutely, Susan. So we've got conversations underway, both to Forester Hill services, obviously not just Aberdeen Royal Infirmary, and also with Raigmore. So both of those things underway, not as far progressed as the Dr. Gray's staff, but underway for both components.
Okay, thank you. I'll take Stephen and then I'll move to the recommendations. Stephen.
Thank you, John. Really, in many ways, I think the conversation has moved on, but it was just going back to the point that Dennis was raising, linking it to the feedback that we received at yesterday's staff governance committee from colleagues working in Murray. I think I am assured, and I think Adam responded well in terms of the formal involvement of a partnership rep in Dr. Gray's strategy. That was something that's been picked up and and has been addressed. But actually, I am assured that the staff in Dr. Gray's and the corresponding staff side organisations are very well aware of the Dr. Gray's strategy and the work that's been done. So I think there's a risk that, and I absolutely understand it in terms of we only had the staff governance committee meeting yesterday, so there's almost a conflation of different issues. But I think the questions, my colleagues on the board have asked are legitimate. But as a new member of the board, I would like to sort of try and assure my colleagues that everything that can be done has been so far and will absolutely be going forward. Thank you.
Okay, thank you. That's really helpful to have your perspective as employee director and with your role with GAPF. Okay, so if we can move to page 124 of the pack, and we have the recommendations on this. We're being asked to confirm that we're assured, and that's in terms of the involvement and engagement for staff and the planned approach to engage with members of the public. So there's those two elements. I'd like to add in that there will be, to the minute, that there will be liaison on the basis of IJB and partners, and that if Dennis and Tracy can be involved in that liaison along with Simon, please. So that's one part of the recommendation. The other one is to agree receiving a further update at our meeting in December, and then the formal strategy to meet the deadline in February. Are we content to approve that with that additional point I've inserted?
Danger.
Agreed, yeah.
Okay, thank you very much. So thank you, Adam, for that. Can we go on to the Grampian delivery plan now, which is item 8 on the agenda, page 126 of the pack. And Lorraine, are you here for this with your colleagues?
Yes, I'm here. Thank you, Chair.
Thank you.
So good afternoon, everyone.
Sorry, I'll just introduce you for people who are listening in. So Lorraine is our Director of Planning, Innovation and Programmes. Thank you.
Thank you, Chair. So the Chief Exec's team are submitting the NHS Grampian delivery plan to the board for formal approval today. There are 2 documents accompanying the covering paper. So there's the full version within the pack, which you'll note is a live document, and also the summary version, which is referenced as Appendix 2, which is a separate PDF document, which is really our summary version, which is much more public staff friendly. Both documents have been developed based on extensive engagement with staff, citizens and partners, building on that extensive engagement as part of the plan for the future development. Board members have also had opportunities to shape and inform the version that's been submitted today. The delivery plan sets out the key challenges, many of which have been already discussed this morning, along with the 3 key objectives and underpinning priority actions and deliverables for the period up to March 23. The 3 objectives are responding to those challenges and also the priorities that staff and citizens have advised us of. Those objectives are, the first one's around reducing delays in accessing care. The second is supporting colleagues to be safe and well at work. The third is around creating the conditions for sustainable change. In the covering paper, we have illustrated on page 130 the alignment of those 3 objectives to the strategic intent as set out in the board strategy, the plan for the future, and also the 3 key pillars around people, places and pathways. We have also set out the alignment against the 6 Scottish Government priorities which boards have been asked to respond to. Scottish Government have reviewed our plan and have advised that they're supportive of this, and we received a letter on the 22nd of September advising that the Scottish Government is content for the delivery plan to come to the board for formal approval. The covering paper also sets out the mechanisms to monitor and performance assure against the delivery and the risks set out in the delivery plan. We have regular monitoring in place, and there is also formal quarterly reports going to board committees as part of the board assurance framework and also to the Scottish Government. In addition to this, we will also have regular mechanisms for communication with staff, citizens, communities and partners in terms of our priorities and our overall delivery. In addition to the 1-year delivery plan, I would like to ask board members to note the proposed stages and the timescales for the engagement in the development of the 3-year delivery plan for the period April 2003 to March 26, and that draft plan we expect to be submitted to the board prior to submission to the Scottish Government in February. And within the covering paper, just like to highlight that we have set out a number of opportunities for board members to shape and inform that 3-year plan before it comes back to the board in February. So thank you, Chair, and happy to take any questions.
Okay, thank you very much for that, Lorraine. And as a board, we were able to give this close scrutiny before it went to the Scottish Government. Really just sort of tidying up any aspects or on catching up with the feedback that we've received, and then moving to the particular recommendations, including the work for the next stage of delivery plans. So can I just open that up if there are any clarification or questions required here? Luann, please.
Thanks, Lorraine. And I do feel that the board have been really very heavily involved in this, so I don't have any specific questions on the content. What I'm interested in is how we're doing integrated comms with our IJBs around the priorities. I think our local councillors are really key assets for us to get the messages out into our communities, so people know what to expect when they need to engage with health and care services. So it was just understand the specifics around doing integrated comms with IJBs. Thank you.
Thanks, Luann. So there are a number of mechanisms that we have in place in terms of both the plan for the future and also in terms of the delivery plan. So one of the pieces of work that we're doing is working very closely with our planning colleagues who are developing their strategic plans or have already developed their strategic plans and delivery plans, to ensure that those areas where there are common themes and areas of focus, that we are looking at how do we much better communicate some single messages around that, both to staff and public and communities around that. So that work's ongoing. So there has been a number of mapping pieces of work around that, and that has definitely been built into our communications as we go forward. And again, we have ongoing links in terms of strategic planning level, and also as part of our ongoing dialogue and networks in terms of with the integration joint boards and the officers around that.
Okay, Luann.
Yeah, thank you. That's helpful. I think just a sort of offer really that please use your IJBs and the members to get the messages out. We're all part of the one system, so I'd be really supportive of anything that IJB members can do to help people that are maybe not on social media, understand the priorities. So please see the IJBs as a resource to help with the core messages. Thank you.
Well done. Thank you, Luann.
Okay. I don't see anybody else signalling. So if we can move to the recommendations, page 135 of the pack. So we've got 3 here, formally endorsing the priorities as set out in the plan for up to March 23, and noting the emerging ambitions. That's the first one. The second one, agreeing to receive the further updates on the development of the performance assurance reporting mechanism for committees, and that will align to the delivery plan, and agree that there are a number of risks which may be negatively impact on the successful implementation of the delivery plan, and then the controls for mitigating that. So those are the recommendations. Before we just confirm that, Lorraine, have you got everything you need from us? You were talking about the future planning. Is there anything else you want on that?
I think at our recent workshop, I think I received the steer that I needed at that, and we'll take that back to future board meetings. So I think I have everything at the moment. Thank you. Okay, thank you, Lorraine. So the 3 recommendations, are we happy to approve those today?
Yeah. Don't you?
Yeah. Okay, thank you very much. So if we can go on to item 9, which is the committee reports, and we have one from Engagement and Participation Committee, and this was the final meeting of that committee before it morphs into the Population Health Committee as one of the 3 key strands for population health. Amy, who's chair of that committee, is not with us today, but Stuart Humphreys is here. and Stuart, who's our Director of Marketing and Corporate Communications, as author. Stuart, would you like to introduce this for us?
Yes, thank you, John. Just by way of introduction to the paper, I think I'd just like to say that sort of since the August meeting was the last of the Engagement and Participation Committee, the members felt that capturing the ongoing items that it was concerned with and sharing the accumulated knowledge from workshops the committee had held over the past year, as well as some of the personal reflections from its members, would be extremely beneficial in supporting a smooth transition of its responsibilities to the new Population Health Committee. So NHS Grampian has had a dedicated committee around public involvement and engagement for a number of years, which has assured the board that our communication strategies are effective. We have a breadth of voices that are heard in cases of major service redesign, as well as assuring that our commitments to equality and diversity within the workforce, as well as through the delivery of our services, are met. Now, as part of the review of the board committees, that commitment will now be taken forward by the Population Health Committee, which is scheduled to meet in November, as well as, I should add, that committee will also look at NHS's Grampians' ambition to redress the organisational balance of responding to ill health with investing in preventing harm and promoting well-being, as well as integrating services to support communities to thrive. So the new committee will focus on this ambition to repurpose NHS Grampian as a population health focused organisation. I think I'd like to just summarise by saying, if I could share one of the reflections from a committee member, I think which sums up the EPC's work very well, which was, and I quote, "I think there was a sense of pride amongst those on this committee, knowing that we were one of the few boards in Scotland that had a committee with a focus on different aspects of the patient and wider public experience of using our services. And I hope that this focus will still have a place somewhere to ensure that as we move through all of the transformation that's needed and execute the plan for the future, that we do this in a way that ensures that the patient and their experience is always in the middle of everything we do," which I think sums it up quite nicely. So with that in mind, the board is asked to endorse the paper put forward by the EPC and support the ask from EPC that the new Population Health Committee consider both the opportunities and the issues it highlights when it's planning its programme of work over the coming year. Thank you very much.
Thank you, Stuart. That was a really helpful overview. So any observations, questions on what we're asked to approve today? Luann.
Thanks, John. Thanks, Stuart. I suppose it was really helpful to see all the kind of the areas that the EPC had been looking at. I'm just looking for some assurance that there is operationally all those areas are being looked at and considered in detail, so that we're not losing them. It's just that the remit of the population health is wider, but there's still a need for focus and scrutiny and coming together around all those topics at an operational level. It's just to understand a little bit that that's still being done.
Stuart?
Yeah, happy to come back on that. I think it's work in progress, if I'm honest, Luann. The committee is having meetings in the interim before we meet formally in November to discuss what that looks like, because you're right, the expanded remit will no doubt challenge us in terms of the time the committee has to give due consideration to each of those aspects of its terms of reference. So I think what will be key is the support structures that sit beneath that committee to enable to kind of proceed with that work. But I think the plan is that we will use either that first meeting or one of the first meetings as a workshop with committee members to identify where our areas of focus should lie over the next months. I can see Susan's put her hand up as well to come in on that.
Okay, thanks, Stuart. Susan?
Yeah, no, thanks, Joanne. I think just in support of Stuart's comments, we've got a number of groups picking up the remit that had been covered by EPC in the past, and to ensure that operationally there is a focus and a drive to deliver the key objectives. We are reviewing the structures and trying to streamline them, but equally, as we move towards a whole system way of working, to double check membership as well of the operational groups that sit underneath, so that as we move forward, those structures are supporting a whole system way of working.
Okay, thank you very much, Susan. And I think I don't see anybody else signalling just now, so I think I would like the board to put on record through the minute an acknowledgement for the work of all those members that have been part of that committee, and also that the strategic intent is not in any way to diminish participation and engagement, but to be able to further develop and strengthen that through the new committee arrangements. But that does require the infrastructure to be put in place, and that was one of the reasons that that committee had been drawn into more operational things than be the norm for a governance committee. Dennis, would you like to come in?
Yeah, it was, sorry, Chair, it was a sticky hand and it was refusing to go up. But it was on a point that I think Stuart had mentioned in terms of the work with the EPC, and one aspect of it was that equality and diversity. Now, my understanding, Chair, is that the whole equality and diversity is like a golden thread, and it's something that we acknowledge through, I think, all the work that we do, and it's part of all the work that all the committees adhere to as well. But I'm just wondering, Chair, if part of the population health, that they would have perhaps the overall lens, say, within that equality and diversity, and that's just to provide that assurance that it is actually something that we will adhere to going forward. Thank you.
Yes, I'm aware that there are three remits, or three parts to the remit for population health, and equality, equity of service provision is front and centre as one of those three, along with people-powered health, which is the participation and engagement part, and with population health more widely, incorporating public health. But Susan, as lead on that, do you want to just confirm or add to any comment?
Yeah, no, that's absolutely right, Dennis, and you'll be aware from conversations with Sarah and others, there are a number of themes tackling inequalities that run across all of our governance structures, and we're working through with each of the governance boards that we are considering issues at the right time, and we have a mechanism for pulling them together. So I think very much work in progress, but in the meantime can provide assurance the Population Health Committee will oversee the work that the EPC did.
Okay, thank you very much. So can we move to the recommendation then on page 168 of the pack? And the paper asks us to have the information coming from that committee passed to the Population Health Committee. And I think we would want to agree that, but I'll come to you to endorse that in a moment, along with a thank you for doing that piece of work as part of the handover, but also an acknowledgement of the work of all the members of the EPC committee. Are we happy to take that recommendation with that amendment?
Yeah, content, Chair.
Thank you very much. So if we can move to item 10, which is the Forum and Integration Joint Board reports. 10.1, we have Area Clinical Forum first. And Kim, is there anything you would like to say by introduction? And then I'll open up for any comments on your paper. Thanks.
Yeah, thank you, Chair. Apologies, I don't seem to have a working camera today. Just a little note, the last meeting that we had, we usually have a really good attendance, but it clashed with the National Treatment Centre meeting. But it's really good that we were invited along and we're certainly engaging with that process. So so a few of our members are missing from this meeting. I think that the main thing really to point out from this is that we're still trying to get ourselves reintegrated, I suppose, into the new system, and find where Area Clinical Forum fits and is of best benefit to the overall system. But it's a slow process, and I know that there are significant challenges in the system, as we've been discussing all morning, but we're still not there yet, and still really looking for a steer from the leadership team around how we can do that and some more integration with the portfolio. So we've had some success, but still working on that. Thank you.
Okay, thank you, Kim. So that probably is the second point on your note about ACF integration. Can I ask Adam to come in on that?
Yeah, thanks very much, John, and thank you, Kim. So we've been working with Kim. Kim hosted a really good workshop a number of months ago to try and think about the sort of next chapter of ACF, and part of that is absolutely that integration with portfolios. And I'll maybe ask Paul Baku for a comment. I know Kim's making some progress with Paul. We've still got more progress to make with other portfolios. And I think it's a kind of an ongoing question for us to keep teasing away at with Kim and colleagues. You know, how do we make best use of ACF and the advice that they can support our system with? You know, we've been trying the commissions, and again, Kim mentions one of the commissions in her update. So I think we need to keep all looking at it, and it's really positive that Kim's, you know, testing us on that and making sure we're all thinking about how to do it. So, but I don't know if Paul B would be happy to, if that's okay, John, just to make a comment from his portfolio perspective.
Certainly, please come in, Paul.
Okay, thanks. And firstly, Kim, apologies for clashing diaries. I do apologise. So, as a sort of a lived or worked example, after I think it was 3 board meetings ago, Kim and I sort of put some time aside, and I think we've met once or twice on a one-to-one. She as the ACF chair and I as a portfolio lead. And I think one of the things that we've been trying to do is understand what the overlap is, where we can do things, and that's where I was at the beginning. But what I soon realised is finding the overlap is one thing with the ACF, but it's also understanding better the roles. So as a portfolio executive lead and the portfolio team, we're very operational. We're strategic to a degree, but very operational. It's very here and now. And when we invited Kim to come to our portfolio team meeting, it really did become clear that one of the roles for the ACF as it is at the moment is around professional roles, and therefore it's not understanding. It's understanding where a portfolio delivering operational services and provision. How do you kind of define questions and scope so that it does overlap, so that you have engagement to co-develop as opposed to what I was doing, sharing and updating. So I think that's a bit of work that we're currently doing, is understanding how the role of the ACF chair and the team does in fact complement. We know it does. It's working out how the portfolio stuff. And the second thing is a lot of the work of a portfolio is very now, and a lot of the conversations and the communications between the portfolio team and Kim and her committee and her members just can't happen fast enough for them to input into the work that we're doing. But again, that's, you know, it's a challenge, but it's not something that's beyond the scope of possibility, I'm sure. So they're the sorts of areas that we're working in. Of course, Kim, together with as the chair of the ACF, and Stuart as the chair of the GP subcommittee, are both representatives on our programme board for the integrated surgical care portfolio. So that's what we're doing at the moment with Kim and colleagues. Thanks.
Okay, thank you very much. I think it's helpful for us to have that bit of detail behind what's been presented by Kim, and be assured that people are actively working through the issues for connecting up with the forum. Can I just ask a question on the 5th point, which is about the board programme? Sarah, can I bring you in to give a comment on that, please?
Yes, I'm happy to share it with Kim, of course, and also I think the ACF might find the committee planners helpful too. So I'll make sure that they're shared periodically with Kim.
Okay, thank you very much. Okay, Kim, so you're asking us to note the points that you've raised, and we've given some scrutiny of those points. Are you content, and is everybody else content to note the report? Okay, thank you. Can we move on to GAPF? And in a similar way, can I bring Stephen in? This is your report on a couple of meetings. Anything you'd like to particularly highlight?
Thank you, John. Yes, the report reflects August and September's meetings, which, of course, were the meetings where it was Rachel's last one as the staff side co-chair and my first one as the staff side co-chair. So it sort of straddles that change. I guess for folks' attention, given the discussions we've had earlier this morning, with all the pressures on the system, I think the section on the derogations and the impact on staff, I think is it sort of hopefully assures colleagues on the board that GAPF has absolutely been aware of the pressures and aware of the impacts on staff and how we can mitigate those as best we can. And I guess in terms of horizon scanning, I would just draw colleagues' attention to the short life working group for potential industrial action, and the work that's been started on that as well. Happy to take any questions, Sean. Thank you.
Yeah, thank you, Stephen. Are there any questions on what we've been provided with here? Okay, thank you. So we can note the information, and I think it's helpful for the board to know that these issues are being attended to through the forum. Thank you. And then the third part of this is the integration joint board. So Sandra, are you here today just to speak to this?
Yes, thanks. Thanks, John. The papers, I suppose, laid out and the key matters are highlighted from each of the 3 health and social care partnerships. So just really happy to take any questions. I think the paper's quite self-explanatory.
Yeah, I think so. Thank you. So similar way, any questions or comments for Sandra on this? Okay, I think that, as you say, it's self-explanatory and covers that clearly. So if we can note the position with that. So that takes us to item 11, and these are the approved committee and forum and IJB minutes. So they're really here for being in the public domain. Are there any issues that anybody needs to raise on any of these? I'll take them all as a, I'm not going to go through each one individually. Is there anything anybody wants to raise? Okay, no, that's fine. So we'll note all of those minutes. That takes us to item 12, which is any other business. The only thing I was going to note here, Amy had advised me, and as I mentioned earlier, she's not able to be here today, but the Spiritual Care Committee is holding a workshop very soon, and they'll be looking at their reviewing their remit and what their current focus is, and so we may hear from that in due course. So it's just for board members to be aware of that particular committee and what it's doing. Any other business anybody wants to raise? Okay, so that just takes us to noting the date of the next meeting, which is Thursday, the 1st of December. That brings us to a close for this item, which is the open meeting, the open public meeting today. Can I thank everybody for your attendance and your contributions? That feels like we've given some thorough assurance on those items. And the board members, can we reconvene at 1 o'clock in the different link, which is for the closed meeting, where we've got a couple of items. Okay, thank you very much.
Thank you, Chair.
Thanks, John.
Thank you.
Thanks, John. Cheerio.